Good morning. First of all, I would like to thank Dr. Ashish and the organizers of KSOS for giving me this opportunity. My topic is fine-tuning nucleus delivery in SICS. As we all know, there are two main obstacles in nucleus extraction. First is at the level of the capsular bag and then at the level of the sclerocorneal tunnel. So a successful nucleus management, for that we need to prolapse the nucleus out of the capsular bag into the anterior chamber first and then extract the nucleus out through the sclerocorneal tunnel. The instruments that we use are the Sinskey hook, irrigating Y vectis, cystitome, and the viscoelastic with its cannula. Prolapsing nucleus into the anterior chamber can be done by hydrodissection with a Sinskey hook and with two Sinskey hooks. Prolapsing nucleus into AC by hydrodissection. Here we insert the tip of the cannula under the rhexis margin and slowly and steadily inject saline. Now the fluid wave advances under the nucleus and we can see that one pole of the nucleus is prolapsed. This step is best done under the retroillumination setting of the microscope whenever available, and a large capsulorhexis also helps in doing this step. Prolapsing the nucleus into AC with one Sinskey hook. So after hydrodissection, you have to dial the nucleus to make sure that it is free to rotate in the bag. Now hook one edge of the equator with a Sinskey hook and then slowly cartwheel it out into the anterior chamber. Prolapsing into the anterior chamber with two Sinskey hooks. Here it's also called the double dialer technique. Here we can see that the one hook elevates the superior pole of the nucleus. Then we place the other hook under the elevated superior pole. And now using the lower one as a fulcrum, we cartwheel the nucleus out into the anterior chamber. As we have expressed it into the anterior chamber, now we have to take it out of the sclerocorneal tunnel. It can be done by different methods. First we will see visco expression. We have to apply visco above and below the nucleus and then inject visco by placing the cannula under the nucleus. Apply pressure on the posterior lip of the sclerocorneal tunnel and bring the nucleus out. Always be careful to inject a sufficient amount of visco to protect the endothelium and below the nucleus to protect the capsular bag. This is a Y vectis method. Again, under the cover of viscoelastic, insert the irrigating vectis with its concave side up and slowly inject saline. By putting pressure on the posterior lip, we take the nucleus out. Always remember to check the patency of the vectis before you start. In sandwich technique, we use the dialer and the Y vectis. The nucleus is sandwiched between the two and by applying pressure on the posterior lip of the sclerocorneal tunnel, we bring the nucleus out. In a phaco-fracture technique, we use a Y vectis and a Sinskey hook, and the Sinskey hook is used to divide the nucleus into two in the anterior chamber, and then each of the pieces are brought out. Take care to use sufficient amount of visco. We need only a smaller sclerocorneal tunnel, thereby minimizing our astigmatism. Now, fish hook technique is a less used technique where we use a 30 gauge needle shaped like a fish hook to hook the undersurface of nucleus and we bring the nucleus out of the tunnel. Now, why do we need to fine-tune our nucleus delivery techniques? Because that fine-tuning helps us to deliver the nucleus smoothly and safely through our small tunnel. It helps us to prevent complications like zonulodialysis and posterior capsular rupture, corneal damage, inferior iridodialysis, especially if the vectis is placed inadvertently below the lower pupillary margin, then Descemet's membrane detachment, and also to ensure minimal wound distortion for faster healing. Now, how can we refine our nucleus management techniques step by step? As we all know, EC nucleus management is preceded by perfection in our previous steps. The superior rectus bridle suture, which we apply initially, provides the necessary counter traction while we are delivering the nucleus. Always aim for an ideal size CCC, especially in the case of hard cataracts, and for beginners, a slightly larger rhexis would greatly benefit while we are delivering the nucleus. And as we heard in the previous talks, The sclerocorneal tunnel should be made keeping in mind the size and the density of the nucleus. If it is a larger nucleus, we need to make a slightly larger tunnel, and special care should be taken in fashioning the side pockets. A good hydrodissection separates the nucleus from the capsule, and after hydrodissection, under viscoelastic cover, confirm that the nucleus rotates freely in the capsular bag. Now fill the anterior chamber with viscoelastic to coat the endothelium and prolapse the nucleus into the anterior chamber. Once the nucleus is prolapsed, apply visco to protect the endothelium and apply visco under the nucleus to protect the capsular bag, and gently engage the nucleus into the tunnel by whichever methods you are comfortable with. Apply pressure on the posterior lip of sclera and bring out the nucleus out of the sclerocorneal tunnel. Should never push or pull the nucleus out forcibly. Now we will see management of few difficult situations. First is that of a hard cataract. Here we are using the two dialer technique to bring the nucleus out. One dialer is used to bring the superior pole up, other dialer is placed below it, and the nucleus is slowly cartwheeled out into the anterior chamber. Now, before we, here we are going to use a wire vectors to deliver this nucleus out. And before starting, you should make sure that the tunnel size is adequate. Otherwise, always enlarge it. And as it is being expressed out, you can see that the superior rectus bridal suture gives the necessary counter traction. Then whenever we encounter a small capsular excess, a nucleus delivery can tend to be difficult. So always enlarge it by double rexus method, where you give a small tangential cut in the rexus margin and enlarge it with the forceps to get an adequate sized rexus. In a relatively small sized capsular rexus, the double dialer technique is makes it easier for us to bring the nucleus into the anterior chamber. Now, small pupil is a condition which we frequently encounter, and it makes the nucleus delivery difficult. So, preoperatively, try to achieve the maximum possible dilatation. You can keep cotton plate jets soaked in Tropic SL Plus in the inferior fornix 30 minutes before surgery, and during the surgery, you can use intracameral tropicamide and phenylephrine intracamerally. And still, if you are not achieved the adequate dilatation, we can go in for a stretch pupilloplasty, where we use two Y pushers or Coughlin hooks to stretch the pupil in the opposite directions, induce some sphincter tears, and that might give us adequate size of the pupil to work with. Pseudoexfoliation is another condition which makes our nucleus management difficult, mostly due to poor pupillary dilatation and also associated zonular weakness. Here also, try to achieve the maximum possible dilatation with the help of the viscoelastics as well as intracameral agents, and if that is not enough, always can try mechanical stretching. And if any zonular dialysis is noted, we should use a CTR. So these are my references. Thank you.
Thank you, Dr. Sumi, for helping us with that very crucial step of nucleus delivery. So many techniques to learn.